Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching critical care nursing. As continuation to our topic on the response to altered sensory and perceptual function, we have the cerebrovascular accident or stroke. Stroke occurs when there is ischemia or inadequate blood flow to a part of the brain or hemorrhage into the brain that results in death of brain cells. Functions such as movement, sensation, or emotions that were controlled by the affected area of the brain are lost or impaired. The severity of the loss of function varies according to the location and extent of the brain involved. In the Philippines, ischemic stroke accounts for 70% of all cases, while hemorrhagic stroke accounts for the remaining 30%. The term brain attack is also used to describe stroke. This term communicates the urgency of recognizing the clinical manifestations of a stroke and treating a medical emergency, similar to what would be done with a heart attack. Following the onset of a stroke, immediate medical attention is crucial to decrease disability and death. If one experiences a stroke or brain attack, he or she is in what is known as 30-30-30 situation. That is, 30% die, 30% are lucky and can go back to the normal, and 30% are left with disability. Now let's proceed to the types of stroke. Strokes are classified as ischemic or hemorrhagic based on the cause and underlying pathophysiologic findings. First, we have your ischemic stroke. It results from inadequate blood flow to the brain from partial or complete occlusion of an artery. Under that, we have your transient ischemic attack or TIA. It is a precursor to ischemic stroke. It is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia, but without acute infarction of the brain. We also have your thrombotic stroke. It occurs from injury to a blood vessel wall and formation of a blood clot. And also we have your embolic stroke. It occurs when an embolus lodges in and occludes a cerebral artery, resulting in infarction and edema of the area supplied by the involved vessel. On the other hand, hemorrhagic stroke results from bleeding into the brain tissue itself. It is classified into intracerebral or intraparenchymal hemorrhage or subarachnoid hemorrhage or intraventricular hemorrhage. Hemorrhagic strokes account for approximately 15% of all strokes and result from bleeding into the brain tissue itself. It could either intracerebral or intraparenchymal hemorrhage or into the subarachnoid space or ventricles. We call that a subarachnoid hemorrhage or intraventricular hemorrhage. Intracerebral hemorrhage is bleeding within the brain caused by a rupture of a vessel and accounts for about 10% of all strokes. The prognosis of patients with intracerebral hemorrhage is poor. The 30-day mortality rate is 40% to 80%. 50% of the deaths occur within the first 48 hours. And hypertension is the most important cause of intracerebral hemorrhage. Other causes include vascular malformations, coagulation disorders, anticoagulant, and thrombolytic drugs, trauma, brain tumors, and ruptured aneurysm. The other one is subarachnoid hemorrhage. Subarachnoid hemorrhage occurs when there is intracranial bleeding into the cerebrospinal fluid-filled space between the arachnoid and pia mater membranes on the surface of the brain. It is commonly caused by rupture of a cerebral aneurysm, that is, weakness and ballooning of vessels. Now let's proceed to the nursing diagnosis. We have decreased intracranial adaptive capacity related to decreased cerebral perfusion. We also have ineffective airway clearance related to decreased level of consciousness, and impaired physical mobility related to neuromuscular and cognitive impairment. We also have impaired verbal communication related to residual aphasia, and unilateral neglect related to visual field cut and lost on one side of the body, and impaired urinary elimination related to impaired impulse to void, and impaired swallowing related to weakness or paralysis of affected muscles. And lastly, situational low self-esteem related to actual or perceived loss of function. Now let's have the planning. So we have to maintain stable or improved level of consciousness, attain maximum physical function, attain maximum self-care abilities and skills of our patient, maintain stable body function, maximize communication abilities, maintain adequate nutrition, avoid complication of stroke, and maintain effective personal and family coping. So here are the emergency initial management of patients with stroke. First, we have to ensure patent airway and call stroke code or stroke team for help, and remove dentures. Assess for patient's oxygenation by the use of pulse oximeter. Maintain adequate oxygenation. The patient's oxygen saturation should be more than 95% with supplemental oxygen if necessary. We also have to establish intravenous access with normal saline solution. Maintain blood pressure according to guidelines of the cardiac life support. Remove clothing. Obtain CT scan immediately, and perform baseline laboratory test immediately and treat if hypoglycemic. Position head midline and elevate head of the bed 30 degrees if no symptoms of shock or injury. Institute seizure precaution in anticipation for seizure. Anticipate thrombolytic therapy or for ischemic stroke. Keep patient nothing per orem or NPO until swallow reflex is evaluated. For the ongoing management, we have monitor vital signs and neurologic status, including level of consciousness, by the use of your NIHSS stroke scale, motor and sensory function, pupil size and reactivity, oxygen saturation, and cardiac rhythm. We also have to reassure patient and family. For the collaborative therapy, we have the prevention. We have to control the hypertension, control diabetes mellitus, treatment of underlying cardiac problems, and also we have to encourage our patient to stop smoking and limit alcohol intake. For the drug therapy, we administer platelet inhibitors and anticoagulant therapy for patients with atrial fibrillation. For the surgical therapy, we have carotid endarterectomy, stenting of carotid artery, transluminal angioplasty, extracranial intracranial bypass, and surgical interventions for aneurysm at risk of bleeding. For the carotid endarterectomy, the plaque that is deposited on the walls of your cerebral blood vessels are being removed in order to restore the circulation. For acute care, so we have the maintenance of airway, fluid therapy, treatment of cerebral edema, and prevention of secondary injury. For ischemic stroke, so we have here the administration of tissue plasminogen activator or TPA intravenously or intra-arterially. Also we have your okay. Also we have your mechanical embolus removal in cerebral ischemia or MERCY retriever. It removes blood clots in patients who are experiencing ischemic strokes. The retriever is a long, thin wire that is threaded through a catheter into the femoral artery. The wire is pushed through the end of the catheter up to the carotid artery. The wire reshapes itself into tiny loops that latch into the clot, and the clot can then be pulled out. To prevent the clot from breaking off, a balloon at the end of the catheter inflates to stop blood flow through the artery. For your hemorrhagic stroke, so we have your surgical decompression if indicated to decrease further bleeding. And also, we have clipping or cooling of aneurysm. Now let's proceed to seizure disorders and epilepsy. Seizure is a paroxysmal, uncontrolled electrical discharge of neurons in the brain that interrupts normal function. Seizures are often symptoms of an underlying illness. They may accompany a variety of disorders or they may occur spontaneously without any apparent cause. Seizures resulting from systemic and metabolic disturbances are not considered epilepsy if the seizure ceases when the underlying problem is corrected. In the adult, metabolic disturbances that cause seizure include acidosis, electrolyte imbalances, hypoglycemia, hypoxia, alcohol and barbiturate withdrawal, dehydration, and water intoxication. Extracranial disorders that can cause seizures are heart, lung, liver, or kidney diseases, systemic lupus erythematosus, diabetes mellitus, hypertension, and septicemia. Epilepsy, on the other hand, is a condition in which a person has spontaneous recurring seizures caused by a chronic underlying condition. The estimated prevalence rate of epilepsy in the Philippines is 0.9%, or approximately 750,000 cases. Most of those with epilepsy are in the productive years of their lives. National trends show that incidence of epilepsy is decreasing in children and increasing in the elderly. The highest incidence of new onset epilepsy occurs in people over 60 years old. New cases of epilepsy are more common in socially disadvantaged population. Males are slightly more likely to develop epilepsy than females. Populations at higher risk to develop epilepsy include those with Alzheimer's disease, those who have had stroke, and persons with a parent who has epilepsy. Now let's proceed to the seizure classification. So I have here the algorithm for the classification of seizure. Seizure is classified into two major classifications. We have your partial seizure and generalized seizure. For your partial seizure, if the patient is alert, that means the patient is experiencing simple partial seizure. For patients who have altered consciousness, so that is your complex partial seizure. For generalized seizure, it is divided into two. We have your probable altered consciousness, under which we have your generalized tonic-clonic seizure and absent seizure. For other subclassification of generalized seizure, we have brief or possible altered consciousness. Under that, we have your clonic seizure, tonic seizure, myoclonic seizure, and atonic seizure. For the complications of your seizure, we have your status epilepticus. It is a state of continuous seizure activity or a condition in which seizures recur in rapid succession without return to consciousness between seizures. It is the most serious complication of epilepsy and is a neurologic emergency. Status epilepticus can occur due to any type of seizure. During repeated seizure, the brain uses more energy that can be supplied. Neurons becomes exhausted and cease to function. Permanent brain damage may result. Tonic-clonic status epilepticus is the most dangerous because it can cause ventilatory insufficiency, hypoxemia, cardiac dysrhythmias, hyperthermia, and systemic acidosis, all of which can be fatal. For the nursing diagnosis, we have ineffective breathing pattern related to neuromuscular impairment. We also have risk for injury related to loss of consciousness during seizure activity. We also have ineffective coping related to perceived loss of control. Ineffective self-health management related to lack of knowledge about management of seizure disorder. For the planning, so we have to make sure that our patient should be free from any injury during a seizure, have optimal mental and physical functioning while taking anti-seizure drugs, and have satisfactory psychosocial functioning. For the emergency initial management, so we have to ensure patent airway, protect patient from injury during seizure by way of not restraining and applying pad to the side rails of the patient. This is to prevent injury. Also remove or loosen tight clothing. Stay with patient until seizure has passed. Suction as needed. Assist ventilations if patient does not breathe spontaneously after seizure. Anticipate need for intubation if gag reflex is absent. Establish intravenous access and anticipate administration of phenobarbital, phenytoin, or benzodiazepines to control seizures. For the ongoing management, we have to monitor the vital signs, level of consciousness, oxygen saturation, GCS results, and pupil size and reactivity. Reassure and orient the patient after seizure, and never force an airway between a patient's clenched teeth, and give intravenous dextrose for hypoglycemia. So what are our safety alerts? During seizure, the nurse should do the following. First, maintain patent airway. Also, we have to protect the patient's head, turn the patient to the side, loosen constrictive clothing, and ease patient to the floor if seated. Do not restrain the patient, and do not place any objects in the mouth. Now let's proceed to your spinal cord injury. Before World War II, the life expectancy of a person with a spinal cord injury or SCI ranged from months to 10 years from the onset of injury. Today, with improved treatment strategies, even the very young patient with an SCI can anticipate a long life. The prognosis for life is generally only about 5 years less than for person of the same age without SCI. The cause of premature death in the patient with tetraplegia or paralysis of both arms and legs, which was formerly called quadriplegia, is usually related to compromised airway function. Your spinal cord injury occurs in the following situation, such as falls, diving, and vehicular accident. It results to the following effects below the level of the lesion. We have your paralysis, loss of reflexes, loss of sensory function, loss of motor function, autonomic dysfunction as well. Here are the classifications of your SCI or spinal cord injury. Spinal cord injuries are classified by the mechanism of injury, skeletal and neurologic level of injury, and completeness or degree of injury. First, we have your mechanism of injury. The major mechanisms of injury are flexion, hyperextension, flexion rotation, extension rotation, and compression. The flexion rotation injury is the most unstable of all injuries because the ligamentous structures that stabilize the spine are torn. The injury is most often implicated in severe neurologic deficits. Next, we have the level of injury. Skeletal level of injury is the vertebral level where there is the most damage to vertebral bones and ligaments. On the other hand, neurologic level is the lowest segment of the spinal cord with normal sensory and motor function on both sides of the body. The level of injury may be cervical, thoracic, or lumbar. Cervical and lumbar injuries are most common because these levels are associated with the greatest flexibility and movement. Lastly, we have the degree of injury. The degree of spinal cord involvement may either be complete or incomplete or partial. Complete cord involvement results in total loss of sensory and motor function below the level of the lesion or injury. However, incomplete cord involvement results in a mixed loss of voluntary motor activity and sensation and leaves some tracts intact. The degree of sensory and motor loss varies depending on the level of the lesion and reflects the specific nerve tracts damaged and those spared. Next, we have your clinical manifestation. So first, we have the cervical SCI. So the injury is at the C2 and C3 and it is usually fatal. We also have your tetraplegia. It is the paralysis of all four extremities. And there is also respiratory muscle paralysis. Next, we have your thoracic SCI. So we have your paraplegia. It is the paralysis in lower extremities. We also have poor control of upper trunk and bowel or bladder retention. And the patient could have autonomic dysreflexia. This is the injury above T6 and in cervical lesions. We also have your lumbar SCI. There is paraplegia or flaccid paralysis. We also have bowel and bladder retention. For the sacral SCI, we have here injury above S2 in males allow erection but no ejaculation. Injury between S2 to S4 prevents erection and ejaculation for males. And there is also paraplegia. And bowel and bladder incontinence. The higher the level of lesion, the greater is the probability to perform sexually. The lower the level of lesion, the lesser is the probability to perform sexually. And the paraplegic male may experience impotence, and the paraplegic female is capable of pregnancy but unable to experience orgasm. Now let's proceed to the complications of SCI. First, we have your spinal shock. It is also called as neural or areflexia. It is a period of flaccid paralysis and a complete loss of all reflexes. Absence of sweating below the level of lesion can happen. And there is also bowel and bladder retention. Hypotension and bradycardia can be experienced by our patient with spinal shock. Next complication is autonomic hyperreflexia. It is also called as dysreflexia. It occurs in clients with SCI above T6 and it is most often in cervical injuries. There is hyperstimulation of the sympathetic nervous system. It is caused by bladder distension, fecal impaction, and skin stimulation. And the manifestations are severe headache, blurring of vision, nasal congestion, hypertension, bradycardia, and sweating above the lesion, and pilomotor spasm below the lesion. Next complication is your whiplash injury. It is caused by violent hyperextension and flexion of the neck. It creates damage to muscles, discs, ligaments, and nervous tissues of the cervical spine. There is also pallor, weakness, gait disturbance, dizziness, nausea and vomiting, occipital headache, and nuchal rigidity. Now let's have the nursing diagnosis. First, we have ineffective breathing pattern related to respiratory muscle fatigue. We also have impaired skin integrity related to immobility, and constipation related to neurogenic bowel. We also have impaired urinary elimination related to spinal injury, and risk for autonomic dysreflexia related to reflex stimulation of the sympathetic nervous system, and ineffective coping related to loss of control over bodily functions and altered lifestyle. Now let's have the planning. So we have to maintain optimal level of neurologic functioning, have minimal or no complications of immobility, and learn new skills, gain knowledge, and acquire new behaviors to be able to care for self or successfully direct others to do so. Also return to home and the community at an optimal level of functioning. For the initial emergency management, we have ensure patent airway, stabilize cervical spine, administer oxygen via nasal cannula or non-rebreather mask, establish intravenous access with 2 large bore catheters to infuse normal saline solution or lactated ringer solution as appropriate, assess for other injuries and control external bleeding, obtain cervical X-ray, CT scan, or MRI, and prepare for stabilization with cranial tongs and traction, and administer high dose of methylprednisolone if ordered. So I have here traction and stabilization, and the application of Gardner-Wills tongs. For cervical injuries, skeletal traction is used less frequently with the development of better surgical stabilization. When skeletal traction is used, realignment or reduction of the injury is targeted. Crutchfield or Gardner-Wills tongs or other types of devices are used to provide this type of traction. Traction is provided by a rope that is extended from the center of the tongs over a pulley and has weights attached at the end. Traction must be maintained at all times, depending on the type of injury and the goal of treatment. The tongs and traction may be removed 1 to 4 weeks after the injury. One disadvantage of skull tongs is that the skull pins can be displaced. If this occurs, hold the head in a neutral position and summon help. Stabilize the head while the physician reinserts the tongs. In a stable injury for which surgery is not done, a halo fixation apparatus may be applied. The halo is the most frequently used method of stabilizing cervical injuries. The halo apparatus can be used to apply cervical traction by means of a jacket-like arrangement. Hanging weights such as those used with tongs can be incorporated with the halo. In addition, the apparatus can be attached to a body vest, stabilizing the injured area and allowing ambulation if the patient is neurologically intact. Another alternative is to use the halo after the patient has had traction removed. It allows the patient to be more mobile and to begin active rehabilitation. Next, we have the ongoing management or monitoring. Monitor the vital signs, level of consciousness, oxygen saturation, cardiac rhythm, and urine output. Keep warm. Monitor for urinary retention and hypertension. Anticipate need for intubation if gag reflex absent. For the collaborative therapy, for acute care, we have immobilization of vertebral column by skeletal traction, maintenance of heart rate by administration of your atropine, and blood pressure by the administration of dopamine. Methylprednisolone, high-dose therapy. Insertion of nasogastric tube and attachment to suction. Intubation if indicated, oxygen by high humidity mask, indwelling urinary catheter, and administration of intravenous fluids, stress ulcer prophylaxis. We also have your deep vein thrombosis prophylaxis due to immobility, and bowel and bladder training. For the rehabilitation and home care, first we have physical therapy that includes range of motion exercises, mobility training, and muscle strengthening. We also have occupational therapy, bowel and bladder training, autonomic dysreflexia prevention, pressure ulcer prevention, and recreational therapy. And lastly, patient and caregiver teaching. Now let's proceed to the diet and nutritional therapy. So we have here your antioxidants. These are man-made or natural substances that may prevent or delay some types of cell damage. Diets high in vegetables and fruits, which are good source of antioxidants, have been found to be healthy. Next, we have your phytochemicals. These are compounds that are produced by plants. Phyto means plant, and it is found also in fruits, vegetables, grains, beans, and other plants, and it protects cells from damage that could lead to cancer. Now let's have the complementary and alternative therapy. So we have here your bilberry. It is a plant. The dried ripe fruit and leaves are used to make medicine. Also sometimes used by mouth to treat eye conditions such as disorders of the retina, cataracts, nearsightedness, and glaucoma. And also we have to educate our patient with regards to the condition and also with the treatment regimen. And for the evaluation, we have to evaluate the outcome of care and report and document care. I think that would be all on the response to altered sensory and perceptual function. Thank you so much, and I hope you learned something today.